It depends on the quality of the embryos, whether they were genetically tested, the age. So there's a lot of factors that go into that counseling. Ultimately, the goal is to achieve a healthy singleton pregnancy. That's going to be the healthiest pregnancy for the baby, for the mother. So that's our goal. Now, when embryos are stored in pairs, it becomes a little bit more challenging because there is going to be some stress put on an embryo if we warm both of them and transfer one and refreeze the other, though that's absolutely something that can and is done, something that I talk to everyone about, especially if we have good quality embryos that are stored in pairs. Or if someone is very opposed to a twin pregnancy, anytime we transfer more than one embryo, there is a risk for a twin pregnancy. And even with one embryo, there's about a 1% to 2% risk of identical twins. Nonetheless, it's shared decision-making, basically. What are these embryo qualities? What is the predicted prognosis with these embryos? What is the anticipated risk of twins if we transfer two? And ultimately, what's going to give you the best chance of a healthy singleton pregnancy?
The situation where I would recommend double embryo transfer is usually an untested embryo from a patient who's 40 or older, but those are few and far between. The problem with multiple gestation has to do a lot both with the complications of pregnancy as well as the complications of a newborn born prematurely. The average gestational age at which a twin pregnancy is delivered is 36 weeks, and the average gestational age at which a triplet pregnancy is born is 33 weeks. When we think about the complications of prematurity, the most severe forms can be permanent lung disease, blindness, deafness, and mental processing issues. And so permanent learning disabilities and all of those issues that go along with prematurity can lead to lifelong complications. And the single best tool that we have to prevent those complications is having a single embryo transfer and trying to avoid a situation of multiple pregnancy.
When we have them frozen in pairs, they really must be thawed in pairs, but that doesn't mean that they have to be transferred in pairs. We can thaw the two, select the best embryo, and if the second embryo is, as expected, good quality enough for a refreeze, we can go ahead and cryopreserve that embryo and save it for a future FET. Vitrification technology has improved dramatically in the past almost 20 years. But we see very high survival rates, though there's always a chance that an embryo does not survive a thaw. If a laboratory is consistently demonstrating 98% survival rates, that's going to mean 1 out of 50 thaws does not survive. And that same rate applies to a refreeze thaw. And so there's a small risk that embryo is going to be affected by the vitrification thaw process. But in general, we see great success with refreezes, and it provides you with that second opportunity for a chance of a successful transfer. So highly recommended.